Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and to delve into the challenges and impact each technology has in practice. This is the Medtronic MedEd learning experience. The BIS monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Reliance on BIS system alone for intraoperative anesthetic management is not recommended. Medtronic's medical education programs are offered to provide attendees education on the FDA-cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidien LP, a Medtronic company, for the speaking engagement. For this segment of the series, a discussion on anesthesia in the brain, we will dive into how BIS monitoring in TIVA and how it may help decrease postoperative delirium. To help answer this question is Dr. T.J. Gann, Professor of Anesthesiology and Distinguished Endowed Chair at Stony Brook University.
Another area that I think that we have not previously focused on, and that is the incidence of post-operative delirium. So this study that shows 81 elderly patients undergoing colorectal procedures, and they looked at standard of care versus standard of care and BIS monitoring, keeping the BIS between 40 and 60. And what they found is that there is a 38%, almost 40% decrease in the incidence of post-operative delirium when they keep the anesthetic using BIS monitoring to about 40 to 60 and show that these patients have a lower incidence of post-op delirium. So there is association between too deep an anesthetic and the incidence of post-operative delirium. So many professional society, including this one, Enhanced Recovery, recommends the use of depth of anesthetic monitoring in a variety of procedures, from colonic, pelvic procedures, gastrectomy, even in ambulatory procedures such as bariatric procedures, as well as the bigger procedures, cystectomy and esophagectomy. So those of you who use BIS on a regular basis, and you will be very familiar with this this diagram here. So essentially, the BIS numbers range from 100, which is fully awake, and down to 0, which is isoelectric EEG. And where we want to keep patients is between 40 and 60. And those of you who are much more interested in looking at what the EEG, it also shows you a raw EEG signal. And as you can see here, that when the patient is awake, you tend to get very small amplitude, high frequency EEG wave. As the patient gets deeper and deeper, the frequency slow, the amplitude tends to widen. And then when you get to the state where the patient is very deeply anesthetized, you get something called the delta wave, which is when the BIS is about below 40. And when you keep the BIS even lower, you begin to see something called burst suppression. And in fact, there is evidence suggesting that burst suppression correlates with incidence of post-op delirium. So the longer the duration of burst suppression the patient is in, the higher the incidence of post-op delirium. So there are a number of important considerations that I just want you to be aware of. There are potentially some artifacts with EEG monitoring, and this is predominantly maybe due to EMG activity or electromuscular activity. Because if you have a patient that you use a neuromuscular blocking agent on, like rocuronium or cisatracuronium, typically the EMG interference is very, very minuscule, almost no EMG, because the muscle is paralyzed. But as the patients recover from neuromuscular blockade, EMG activity may potentially interfere with BIS value, so something to watch out for. And there is a bar called the EMG bar, and if you want to look at your EMG bar, if the EMG bar is high, suggesting that, and if a BIS value is not something that you think that is real, you can look at the EMG bar and you can, once you paralyze the patient or reduce the muscle activity, the BIS value will become more consistent. The other things to think about is that there are certain conditions like hypoglycemia or hypothermia that result in interference of the EEG effect that also can affect the BIS value, is because the brain activity are being affected. And also don't forget that the BIS value that you see on the screen is not the BIS value instant at that time. It is basically it's an averaging over the past few 1 or 2 minutes or so. And again, you can set the window of how quickly you want the monitor to process the EEG, anywhere from 10, 15 to 30 seconds. And there is a time lag. So you got to interpret that number as something that happened 20, 30 seconds ago rather than at that instant. A common example is that my resident tell me that, well, BIS is 40 and the patient is moving. Well, that may be true, but the BIS is not 40 at that time when the patient is moving. BIS was 40, maybe 30 seconds, a minute ago. So usually when you look at the next BIS value, then the BIS jumps up to 70, 80. Now, the other thing that is important to note is that BIS works well with the traditional anesthetic agents such as propofol or the inhalational agents, from isoflurane to sevoflurane to desflurane. And these have all been validated with as validation studies. It works with midazolam, but it does not work with ketamine, because ketamine is a different anesthetic. It works differently from all the other anesthetic. So if you are using ketamine, your BIS value tend to be higher than what it should be.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.